to introduce the next speaker, which is Dr. Joseph Anthony Tumbocon, who is also one of Asia Pacific Glaucoma Society board members. He is the head of the Glaucoma Service, assistant head of the undergraduate education department of St. Luke's Medical Center in Manila, Philippines. And he's also the past president of the Philippine Glaucoma Society. Today he will be talking to us on repair of recurrent tube exposure. Over to you, Tony.
Thank you, SK. Again, okay. Are you seeing my slides?
Yes.
Okay. So, thank you, SK, for the introduction. I would like to thank the All India Ophthalmologic Society and the APGS for inviting me to give a talk in this session. Now, my talk for this evening is repair of recurrent tube exposure using amniotic membrane conjunctival autograft sandwich. I'll describe this later on in detail. This is my financial disclosures, none of which are relevant to this talk. This is my outline. I'll first briefly go into the incidence of tube exposure, how we could prevent them, and how to manage them using the technique I mentioned earlier. Now, if you look at the AVB, ABC, and the TVT studies, the incidence of tube or plate exposure ranges from around 1 to 5%. It's not that common, but if it occurs, it could be quite problematic. It's important that we prevent them from occurring in the first place, but if you do a lot of surgeries, you have a tendency to see one of these, and we need to know how to manage them properly. For preoperative planning, we want to make sure we identify those patients that may be at risk for tube or plate exposure. And these are patients who have extensive conjunctival scarring, thin sclera, presence of ocular surface disease, dry eye, or eyelid malposition. We want to correct any of these reversible risk factors so that you will have decreased the chance of having any tube or plate exposure. Of course, if the patient has diabetes mellitus, you want to make sure that it is controlled before undergoing surgery. To prevent tube or plate exposure, we have to make sure that the plate is positioned properly and secured 8 to 10 millimeters posterior to the limbus. We enter at the correct point, and the trajectory of the tube should be around should be parallel to the iris plane. We want to make sure that the anterior subconjunctival portion of the tube is covered properly, either here, like in this case, a scleral flap, some form of patch like tutoplas or scleral patch graft. And of course, closing the conjunctiva properly, making sure that you won't have any delent formation and it's quite smooth and closed in a quite tidy manner. Now, in this case that I'm going to show, this is a patient who already had a tube around 10 years prior. Patient was a 36-year-old female. Patient had the juvenile onset glaucoma and also cataract. She's already pseudophakic. After around 10 years, the pressure started going up. We decided to place an infero-nasal tube. However, the tube got exposed just after around 4 to 5 months post-op. So in this case, we first decided to do a conjunctival rotation. We did extensive conjunctival dissection and then dissected it to make sure that the healthy portion of the conjunctival will be covering the tube. We also placed a scleral patch graft and then rotated the conjunctiva nasally. As you could see here, healthy conjunctiva covers both the tube and most of the scleral patch graft. However, after 3 months, we had the recurrence of the tube exposure. We noted that the conjunctiva was a little bit quite tight, and this may be causing tension and leading to the exposure. So we decided to use a conjunctival autograft to cover the exposed tube and also put another patch graft. However, a free conjunctival autograft doesn't take well when you place it on top of sclera. So in this case, we utilize a double layer amniotic membrane and it's sandwiched on the conjunctival autograft. As mentioned earlier in the previous talk, amniotic membrane is usually placed on a nitrocellulose paper with the epithelial membrane epithelial side up. And it can be used as a patch wherein the epithelium is placed epithelial side down, or as a graft wherein the amniotic membrane is placed epithelial side up. So if you want to do an amniotic membrane sandwich, you place it the first layer epithelial side up and the upper layer epithelial side down. In this case, we place the conjunctival autograft in between the patch, the amniotic membrane patch, and the amniotic membrane graft. So this is the surgery. So we did dissection. As you can see, even the scleral flap has already melted away. So we let the conjunctiva hang back. There was quite a bit of tension. And then place a scleral patch graft to cover most of the defect over the tube. And then this is the amniotic membrane on the nitrocellulose paper. We place it epithelial side up. So this will serve as a scaffold for the conjunctival autograft. And then sutured it with a 10-0 nylon at the limbus. And then we tucked in excess amniotic membrane underneath the conjunctiva, then sutured the amniotic membrane onto the sclera and onto the conjunctiva. After which we measured the size of the defect, then harvested the conjunctival autograft superinasally. And then just flipped it over the conjunctiva. Flip the conjunctiva over the cornea. Then cut it. And then just rotated it at the area of the defect, making sure that it's limbus to limbus. And then now the conjunctival autograft is epithelial side down. We sutured it onto the limbus and then just flipped it over. And then secured it using 10-0 nylon sutures in an interrupted and continuous running suture technique, making sure that the conjunctival autograft is well coaptated with the infero-nasal conjunctiva. Now, again, the amniotic membrane graft will serve as sort of the scaffold. Now here's the amniotic membrane patch. It will help protect the conjunctiva from trauma and make it heal a bit better. So we just fixated this with 10-0 nylon sutures and 6-0 vicryl sutures into the conjunctiva. This patch will eventually melt away after around a few weeks, and then it will leave the conjunctiva quite healthy. So in summary, I just described a technique of how to repair a tube exposure using an amniotic membrane conjunctival autograft sandwich. It's a viable technique for those repairing, if you want to repair recurrent tube exposure, where conjunctival advancement or rotation is not feasible. Again, prevention is really the key, and individualized preoperative planning and meticulous attention to proper surgical technique will help decrease the risk. Thank you very much for your attention, and I look forward to some discussion.